I'm going to sum up for you the proceedings of the American Diabetes Association's 76th annual meeting, which was held in the early part of last month, early part of July. This was a very interesting meeting and quite a monumental meeting with more than about 7,000 presentations spread over about 4 days' time. I have picked up something of great relevance to our clinical practice, and I'm going to comment and try to give you the perspective of whatever study I describe for you. I have divided the subject into the classical subdivisions like etiology and management aspects, and of course epidemiological aspects, and last of all some of the research aspects involving cure of type 1 diabetes. So let us start with the etiology of type 2 diabetes especially, and I must tell you there that a very interesting lecture which was lectured by the President of Science and Clinical Affairs, Dr. Barbara Kahn. It is called Benting Lecture, which is one of the most prestigious lectures of American Diabetes Association. That lecture really was focused on the etiology. So I'm going to take you into that very interesting lecture, which continues to be available at the webcast of the ADA. And in fact, this particular and few lectures are available for free access, so some of you may enjoy looking at this lecture. Very interesting aspect is that this particular lecturer, that is Dr. Barbara Kahn, as well as another very important lecture which is by an outstanding educator award receiver, that is Dr. Sherry Goldberg Hawks, was a very interesting one because both of these individuals are really type 1 diabetics, starting their disease from 4 years age or at the adolescence, and they're continuing for more than 40 or 50 years. So this is very important to see that scientists and clinicians with type 1 diabetes can achieve this kind of eminence and do such good clinical and research work. The lecture by Dr. Barbara Kahn, that is the Benting Medal lecture, was centered on the adipose tissue biology, which is a very important one. We know that adipose tissue, we have earlier on thought that it is a depository of fat tissue, and we did not understand any other importance of this tissue. Subsequently came a period where we started understanding that adipose tissue, you see, is also like an endocrine gland, and it really secretes a lot of very important hormones, and you all are familiar with some of the hormones like leptin and adiponectin and many others being poured by these. Another very important one which Dr. Barbara Kahn and her co-workers discovered was a protein called retinol binding protein 4, which has effect of increasing insulin resistance. So this is a very interesting protein which she described in detail. Another very important aspect which emerged from her talk is that of energy balance. Adipose tissue is not only a passive storage tissue, but it is very actively involved in energy balance. We always think that the muscular tissue, the bowels, liver are involved in energy balance, but adipose tissue also is equally important. And it does so through the mediation of leptin hormones, as well as some of the very famous reactions called white adipose tissue, turning into what we call brown or beige. So it's called browning and beiging processes of white adipose tissue. You all know very well that the brown adipose tissue has very large number of mitochondria, which makes it metabolically very active, and therefore it increases the energy expenditure of an individual. Then there are other metabolic aspects of, so the adipose tissue has some very important metabolic function which are shown here. Of course, lipogenesis is very important. So de novo lipogenesis in the adipose tissue is a very important aspect described in this lecture, and some of the lipids synthesized there are very new molecules described, which really increase the insulin sensitivity. And of course, some of these interesting aspects were brought out in this very interesting lecture. So here you see the retinol binding protein on which they work extensively, and that retinol binding protein increases the adipose tissue inflammation, thereby resulting into increased secretion of cytokines like TNF alpha and interleukin 6. And you know that these cytokines impair the insulin signaling systems, and thereby they are going to cause insulin resistance. So this is one very, very interesting piece of information in this lecture. And lastly, Dr. Barbara Kahn described some very novel lipids which are synthesized by the adipose tissue, and these are a combination of fatty acid and hydroxy fatty acids. So it is called fatty acid hydroxy fatty acid combination, and these are synthesized in the adipose tissue, and increased synthesis of these compounds results into increased insulin sensitivity. So this is very, very interesting facet of this work. Now let us look at a very important presentation which was related to epidemiology of this particular of diabetes, and this lecture was by Dr. Gregg, who is from the Center for Disease Control's Atlanta. And Dr. Gregg, of course, first answered this question that what is explaining the slowing of incidence and prevalence of newly diagnosed diabetes. In fact, some of us has postulated, and I did that in one of the editorials in the RSSDI journal about a couple of years ago, that we are going to witness blunting of the epidemic of diabetes and slowly decreasing incidence or prevalence of the disease. And this is now being observed already in advanced countries like US, and I expect that another decade India will also be fortunate to halt the progression of this particular disease. And it is really theorized that is this a chance observation? Probably no. It is real, and I think disease is going to be blunted now. And of course, is it due to saturation of susceptible population? That is a possibility, because whosoever has genetical susceptibility would succumb to the disease much earlier, and thereafter, of course, you will have a population which is not so susceptible to the disease, and hence there is going to be a decline in the incidence and prevalence of the disease. This one particular explanation has been very well brought out in one of my editorials as well, which I mentioned to you earlier. And of course, you see, in the US population, probably it is decreasing, one, because obesity is decreasing, probably diet and nutritional factors are improving. So I think, and of course, are we really changing the detection and diagnosis? There I believe that methods of detection and diagnosis are improving. So if at all it should result into increasing diagnosis, and while reverse is happening, so I think we have to really accept that the disease is getting slowed down. Now, how far are we controlling the risk factors of this disease? And this is very, very interesting to see that if you look at the four very important risk factors in diabetes, that is tobacco abuse, the hyperglycemia itself, and the hypertension and hyperlipidemia, then over different periods of time, as you see here, 1970 to 80, 90 to year 2000s, you will realize that we have not done as well as in controlling the tobacco abuse. However, glycemic control, we have achieved moderately well. In blood pressure control, our achievements are moderate. And in lipid control, we have largely been able to control. So I think the risk factor control is also improving, but certain areas of it still remain untackled by even in the US. Now, one very important thing to realize is that in this epidemiology lecture by Dr. Gregg, he emphasized that the macrovascular disease is now on the decline, which is very, very heartening to know. We know that at the moment this is not occurring in our country, but the macrovascular disease, that is incidence of myocardial infarction, has definitely come down. As you will see, there is a gradual decline. At the moment, it is really, the decline is from almost above 130 per 10,000. Now we are close to almost about 50. So you can see that there will be considerable improvement in this area in the epidemiology of vascular disease. Now I look at the other vascular disease, which are shown in this slide in the same lecture by Dr. Gregg. And here you have stroke and many other problems, diabetes-related complications. and you will see there is a decline all over. However, if you see the renal disease here on this graph, there is not as much decline, and very interestingly he mentioned that the hepatic disease is also being diagnosed more and more. This is probably the result of the chronic liver disease, which you know are now increasingly getting recognized because of hepatic steatosis. You have higher incidence of cirrhosis of liver in diabetics, and this again is going to gain prominence because at the moment we don't have very easy methods of controlling the same. So this was a very interesting lecture by Dr. Gregg. It was a Kelly West Award lecture. You know that Dr. Kelly was one of the leading epidemiologists of US who passed away some time ago, and it is named after Dr. Kelly West. Overall, remember that mortality due to cardiovascular disease is falling in US, and if you go for cause-specific mortality, the cardiovascular mortality definitely falling, while earlier the cardiovascular disease accounted for half of the deaths in diabetics. Now it only makes 1/3 of the deaths in diabetic, and of course, on the other hand, mortality due to kidney and liver disease is on the rise. So this is a very important trend. Now another important thing is that the mortality in older patients is declining. There is tobacco abuse is declining, blood pressure control is better. So you will see that elderly people are having much better outcomes. On the other hand, in young type 2 diabetics who suffer from gross obesity, and even there is tobacco abuse and hypertension, that is disheartening because that is not as well controlled at the present time, while the elderly population is experiencing a good improvement in the incidence of cardiovascular disease. To summarize the changing tides in the type 2 diabetes epidemic among the US adults, see, there is a large reduction in full spectrum of diabetes complications. Macrovascular disease has declined more than micro. You'll notice that earlier on we always thought that macrovascular is difficult to control and micro was the easier, and obviously micro being related to control of hyperglycemia. So we always found that was easier to control. However, it is exactly reversed at the present time, and older people improvement is more than younger people. And I think some of these features which I described to you have been emphasized in this lecture. Now let us take few aspects of therapy of diabetes, and there I'll touch upon metformin, a great molecule, and we all know that it prevented cardiovascular disease to some extent. UKPDS, you know, this is the only molecule which really showed some improvement in macrovascular disease. And very interestingly, Dr. Holman's follow-up study of UKPDS, with which you are quite familiar, 10 years follow-up after the cessation of the study, has been published, and there, interestingly, it has been shown that there is 39% risk reduction in myocardial infarction in people treated with metformin and intensively treated group. And remember that even mortality, there was 36% risk reduction of all-cause mortality. So metformin is a winning molecule and it continues to be recognized as such. Another important thing is, in order to really see the effect of control of hyperglycemia, there is now a very interesting study called GLINT, that is glucose lowering in non-diabetic hyperglycemic trial, which is an ongoing study on 12,000 patients, where control in non-diabetic hyperglycemic, that frankly means people with impaired glucose tolerance have been. Another very interesting aspect which you are quite familiar is the effect of metformin in cancer prevention. And of course there is good epidemiological evidence that diabetics being treated on metformin have lower incidence of malignancy as compared to non-metformin users. And of course experimental studies in mice, and you see large doses of metformin are known to prevent cancer. As a matter of fact, now some data is being discussed where the amount of metformin used falls well within the clinical range that we use in the humans. Now we go to another very important drug, and that is the empagliflozin, and a very important study on empagliflozin, that is regulatory outcome study, which you know was presented last year. But in this particular meeting, what was discussed was the mechanism of cardiovascular protection which is being offered by empagliflozin. And this was discussed by, uh, by Farinani first, and also by Dr. Sundar Godaliar next. Now what Dr. Farinani showed, that empagliflozin in SGLT2 inhibitor, it improves the efficacy of heart by changing energy substrate to beta hydroxybutyrate and or by increasing hematocrit. So there are two mechanisms being postulated. One is that this drug causes mild incipient ketogenesis and elevation of beta hydroxybutyrate, which is a preferred and very efficient energy substrate for the contracting heart muscle. And secondly, they also improve renal function, which was described by Dr. Sundar Godaliar, and they postulated both that one is the ketonemia, and as you know, with the use of SGLT2 blocker, there is always a rise in the ketone levels, and of course beta hydroxybutyrate levels shown here are quite elevated. And then next slide points out the great importance of beta hydroxybutyrate as a substrate. Remember that beta hydroxybutyrate is a very important substrate in the basal state for the myocardium. And as the empagliflozin increases beta hydroxybutyrate, this is the mechanism by which it improves the cardiovascular outcome. And second, of course, there is a consistent elevation of hematocrit only to the extent of about 5%, but it is postulated that both kidney and heart benefit by this increased hematocrit value and better oxygenation of both these tissues. Another very important compound discussed in the therapeutics was albigudide, which you know is a GLP receptor agonist. Of course, this is given, this drug is given 30 milligram initially, followed by 50 milligram dose after 8 weeks, and the drug efficacy has been compared with the basal insulin and with the prandial insulin for the sake of completion of data, I guess, and it has shown not to be inferior. The hypoglycemia with all GLP receptor agonists is minimal, so here it is described to be about 5%, and in fact it only occurs when the drug is used in combination with sulfonylureas or insulin. Very rarely hypersensitivity reaction, very rare possibility of pancreatitis, possibility of C-cell tumor, but on the basis of data that generated, it has been shown that it is not necessary to measure calcitonin levels in these people. The possibility sometimes of acute renal injury, although it remains doubtful, because the acute renal injury can occur in diabetics at large as well. But however, this possibility has been described, and of course delayed gastric emptying is part and parcel of the action of this drug. Cardiovascular outcome data on this drug are not available. Albiglutide has been marketed as Tengium in the other countries. Another interesting aspect of therapy was relating to carb counting. And you know very well that in type 1 diabetics who are on insulin pump, we always train them to do carb counting. As a matter of fact, even not on insulin pump, but on multiple insulin doses also, we teach them carb counting, because each pre-meal dose can be changed depending upon the carbohydrate content of the meal. And therefore, we have always shown that really what you need to count is the carbohydrates in the cereals, pulses, milk and fruit. But now some data are being presented, as it was done by Dr. Gary Steele, that besides carb counting, it is very important to know the fat and protein content of the meal. This also has been appreciated by people who use pumps to a large extent. As shown in this next slide, you'll see that when you have a very heavy, high fat, high protein meal, for example shown here, you will see that very late, after about 2 hours, you will find a blood glucose rise and you will require extra insulin. So you know very well that delayed boluses have been programmed on the pumps, and they are very appropriate for meals which are very high fat and high protein. So I think the aspect is not very new, But now it is being postulated that when we are describing or training our pump users to change their bolus size based upon the meal that they are likely to partake, it is very important really probably to include the protein and fat content as well. So this might figure out in some of the pump equations now as we go along. Another very important therapeutic aspect described was the PCSK9 inhibitors, very, very interesting compounds. To expand the term, the proprotein convertase subtilissin or taxin type 9 inhibitors, a very, very jaw-breaking name for these compounds. They are very interesting compounds because the PCSK9 is a protein which regulates the lifespan of LDL receptors, and it prevents the recycling of LDL receptors. So the LDL receptors cannot be recycled and be reused, and therefore the cholesterol lowering effect of some of the drugs like statin is limited. However, PCSK9 inhibitor increases LDL receptors because but it allows the recycling of LDL receptors because they destroy the PCSK9 protein, which limits the recycling, and this is how it works in lowering the LDL cholesterol. Two compounds which are approved for use, these PCSK9 inhibitors, which we not yet use in India, are alirocumab and evolocumab. And they are injectables, they have to be injected at the frequency of every 2 to 4 weeks, and the cost of these drugs is very high. It almost comes to roughly about $10,000 per year. But indications are for some rare hyperlipidemia, like a familial hypercholesterolemia, where you know very well that the cholesterol can be as high as 600 milligram with very early deaths with cardiovascular disease. So these familial hypercholesterolemia, probably this will be the treatment of choice. And very, very rarely, probably statin intolerance, it will be also one of the options which can be offered. But considering the cost, probably one would like to explore some other alternatives in cases of statin intolerance. The side effect profile of these drugs is relatively benign, so that there is not much to fear on that count. Another interesting aspect of therapy was introduction of concentrated insulins for clinical use. So Eli Lilly used, U500 insulin in a vial form for use by people whose insulin doses are very high, like people using more than 200 units of insulin a day would require concentrated insulin like this. I must tell you that this is now about to happen in India as well. So U300 insulin is about to be introduced in India by Wokhart. So I think this will be again used by a small number of people, but definitely those who have very high insulin doses will prefer this. Obviously, you require good accuracy of the delivery device, which of course has been achieved. Possibility very rarely of dose errors with mismatch of syringes is possible. Glargine insulin 300 has been introduced by Sanofi by name of Toujeo, again by use for people with very high doses. To my mind, this kind of high doses are not very common in practice. As a matter of fact, good insulin therapy really consists of giving small multiple doses of insulin with a very good sensitizing oral agent. So I think once you use that approach, this kind of doses, you are going to witness very, very rarely. About hypoglycemia, some of these important points have been made, and this is shown on this slide. You see that counter-regulation is blunted for a couple of days following a bad episode of hypoglycemia, and in this paper described by Dr. Stephen Davis, it was exercise-induced hypoglycemia, and after which the counter-regulation was known to be impaired for 2 to 3 days' time. And also remember that recurrent hypoglycemia, they have described the glucose output from the liver is also decreased. So it becomes very, very dangerous situation. Hypoglycemia in children, Dr. Tamberlane from Yale described, and he pointed out a threat to neural development in children with type 1 diabetics who go through hypoglycemic episodes. Now we go, in the next slide we show you the near option in non-injectable insulin delivery systems, that is, you see, you see smart insulin is being described, which could be glucose responsive. Some research is on in that regard, although I think it is very difficult, although theoretically very, very beautiful proposition. Now, of course, immune isolation, of earlier we were talking of beta cell immune isolation, now we're talking of stem cell also immune isolation. And of course, another very important facet of treatment which is emerging is called genome editing, that is changing the genes. And the technology used is a very interesting one. One is by using viruses, the program viruses which will change, which will do the editing of the genome in the desired fashion that the experimenter wants to do. And next is the nanoparticles are used to turn the genes off and on. So these two very, very interesting technologies were described, and Dr. Anderson for MIT, the Massachusetts Institute of Technology, discussed some of these technology. Oral insulin, you know, is always a recurring theme in many meetings, and now we're talking about nanosystems for encapsulating beta cells. And very interestingly, this very good work is being carried out at the Chitra Institute at Trivandrum in Kerala, and Dr. Chandra Sharma described this work in this meeting. We talk about bariatric surgery and remission of diabetes, and we all are quite appreciative that it can cause remission of diabetes to the extent of 60% of people, which is very, very amazing results. However, now what is being described is that the type of bariatric surgery makes difference, and the gastric bypass which give you twice the number of remission as compared to gastric banding. So when you are planning bariatric surgery for your patient, you should also discuss the type of bariatric surgery that will be undertaken. For the sake of ease, quite often gastric banding is practiced more than gastric bypass, but I think for diabetes remission, we should insist on gastric bypass as far as possible. In the field of complications, now we'll look at, and very interestingly, the ACCORDS follow-up study, which is called Accordion, described by Dr. Emily Crew, is the 4-year follow-up of after the ACCORD study was terminated, showed 50% reduction in diabetic retinopathy in the intensive group. So again, our belief that there is a metabolic memory effect is being reaffirmed by some of the data, and control of diabetes, adequate control in the early phases is still probably the most rewarding experience for our patients. Now we take up the other complications in this set of slides. Now we look at the glomerular filtration rate, and very interestingly in this study described, it was shown that the GFR can fluctuate by 5 to 10%. Sometimes we don't realize that it will vary day to day. You see, and in diabetics it can fluctuate even more, and it is considered the cystatin C method is probably superior to estimation of creatinine in this respect. Diabetic kidney disease is being looked at again fresh in different way. For example, it is not only the simple Kimmelstein-Wilson lesion, but there is a possibility that it is a conglomeration of a variety of pathologies. And one of them, of course, is generalized arterial-nephrosclerosis. There is now what is being described as an obesity-associated glomerulopathy, and last of all, there is interstitial fibrosis due to aging. So when we look at a patient with kidney disease in diabetes, we have to always be alert to the possibility of some of these alternative pathologies either coexisting or in fact being responsible for this particular kidney failure. And remember that microalbuminuria is not always a faithful reflection of kidney function. For example, even with very low GFR, you see microalbuminuria may not be seen. As a matter of fact, with a decline in eGFR, there is a possibility that microalbuminuria may be a misguiding feature. So I think studies where only microalbuminuria is relied upon may be flawed because of this particular logic. Now, heterogeneity of renal pathology, which I alluded to in the earlier slide also, is shown here. Here you see the normal glomerular. Here, of course, in the second picture, middle picture, you see typical diabetic glomerular sclerosis. And again, you see here in the third, you see the picture, you see atypical pattern of renal injury. So remember that in diabetic kidney disease, many of these other pathologies will also be there, and we should be always alert to to these possibilities. Now, another important thing to know that very early you can see a decline in the estimated GFR, and there I think you see the relying upon microalbuminuria is not good. This is what this particular study shows, that you see between non-decliner and decliner, you see microalbuminuria is not always different. So I think this is very important to know that it is not a absolute faithful indicator of eGFR. Now, if you see epidemiologically, the end-stage renal disease is now also going down to some extent, but not to the same extent, and different age group you see here, decline in end-stage renal disease. To some extent, at least the rise which was occurring earlier has been blunted, and at the moment we are seeing a very, very slow decline in the end-stage renal disease in diabetes. Now, looking at retinopathy as another complication in this slide, is described by Dr. Renu, and very important thing is this speaker pointed out the importance of what is called epigenetics. As a matter of fact, it is postulated that renal damage due to hyperglycemia is an epigenetic phenomenon. It is due to change in the gene function, and therefore, you see, control of hyperglycemia will alter obviously the incidence of retinopathy. Again, showing the importance of epigenetics in this slide. So besides, you see the change in the function of DNA, which occurs primarily due to methylation of histones in the DNA molecule. So those histones can be methylated, and therefore you find some of these differences in the function. So DNA can be methylated, and the histones also can be methylated, and that changes the gene function. So the new directions in diabetic retinopathy is appreciation of epigenetic changes there. Also important, many other drugs and alcohol and tobacco also, and environmental pollution also can produce epigenetic changes and complications. So this is something very, very important to look at from public health angle, and most important, the stem cell therapy is emerging both for diabetic retinopathy and for diabetic corneal disease. And for diabetic corneal disease, this author from Cedar Sinai, Dr. Lujubimu, he described very interesting work being carried out at the Prasad Eye Institute in Hyderabad, which was described as a pioneering work in the stem cell therapy of the corneal disease in diabetes. And of course, the gene therapy is again being considered by viral vectors or nanopolymers, which I described earlier for you. These two modes of therapy are emerging. Stem cell treatment opportunities, again by the same author, and they describe here, you see stem cell injections and change of vascular permeability and electroretinogram changes to the better by stem cell therapy in diabetic retinopathy. And this, of course, is concluding the results in diabetic corneal disease. So you see here corneal disease being treated by stem cell therapy, and that changes the outcomes considerably. Now, I think we very quickly go to the last few slides, and we talk about the immunotherapy of type 1 diabetes, like you see here by one author, anti-thymocyte globulin, and of course some other therapy. And they're combining variety of these immunotherapies to get better results. So multiple immunotherapy described by J. Schuyler in his lecture. And here you see regulatory T cells being changed. You see, and most importantly, another compound called imitinib, which is an oral agent used in chronic myeloid leukemia, is being used now in immunotherapy of type 1 diabetes. This is a tyrosine kinase inhibitor, and it increases insulin sensitivity. So I think with this, we have described some of the very, very important presentations made at the annual meeting of American Diabetes Association. Thank you very much for your careful listening.